Good evening, everybody. And we are having the last talk of this series of our SN Legends here. And we started this small series in the month of May 2025 last year with an inspiring beginning by Dr. Prema Padmanabhan, who is here with us as a talk called Proven Perspectives. And it really proved prospectively to get into the next 8 legends over last 7 months. So we continued the talks with Dr. Lingam Vijaya, T.S. Surendran, Dr. Lingam Gopal, Dr. Nirmala Subramaniam, Dr. J. Biswas, and Dr. B. Shanta. They were handpicked to provide an overview of Netralaya and what they saw over last 30 to 40 years. We chose them to reiterate this introspection to my generation and yours, the youngest Gen Z, what we call, who have just joined the institution. And today's personality, Dr. Pramod Bhende, is a fatherly figure for all of us Vitio Retina Fellows, including me and all our department consultants. Working close with him in OPDs and OTs past more than 2 decades, I observed certain qualities he possesses which is worth mentioning. Patience, composure, principles, and highly meticulous work style, professional values and ethics, and finally, the undeterred commitment to the patient service. These are some of the exceptionally worth mentioning qualities he has. Just to have a real experience last few months, he had 4 ROP babies in his big list, which started the day, and the last 7th complicated case of an adult, which started at 5 p.m. in the evening, went on for 4 long hours, uncompromised, undeterred, and satisfied look at the completion. Something each one of us should inculcate from this personality. If you do something, do it completely with the justification for your work. He's an ardent cricket fan of Rafi's songs. He attends ritually the annual MBBS reunions to meet his old friends. One can imagine the perspectives and balances he has maintained with the people over decades. We have our own Dr. Pramod Bhende, mentor, guide to every one of us, today giving the talk, which is the last in our series. He'll be speaking on the topic Retina Past, Present and Future. With a great pride and admiration, I call upon Dr. PB sir to give his talk. I encourage all of you to have an open interaction with him, and sir preferred to have hot dosas with all of you in the Sky Lounge following the talk.
Thank you, Pradeep. I don't think I deserve that much of, and I think he's ensured that making us feel old now. Okay. Thank you very much once again for a kind introduction. So, after track, basically there was a little bit debate whether I should talk my interest, my specialty, always pediatric retina and ROP, or this is a little bit off the track, little bit different, which covers more generalized thing and little bit history, make things a little bit interesting. And we thought, okay, ROP we can do as academic activity. This is Pradeep. Pradeep was very particular. I think you talk on this totally different, diverse way. And that's why the topic is chosen. So, well, let me start little bit about history. When you look at the Sushruta Samhita, Sushruta considers surgery the first and foremost branch of medicine, and he states, surgery has the superior advantage of producing instantaneous effect by means of surgical instruments and appliances. Hence, it is the highest in value of all the medical tantas. It is eternal and a source of infinite piety. Imports fame, opens the gates for heaven to its water is. It prolongs the duration of human existence on the earth and help men in successfully fulfilling their missions and earning a decent competence in life. So we all know Sushruta is considered the father of surgery, one of the first sage who started surgery all over the world, I would put it that way. And look at his Sushruta Samhita, basically he divided into 6 parts, covering almost all the branches of medicine. I don't think any comprehensive we have, and which obviously all of those 6 ophthalmology is he has given importance. And as we all know, we all hear about that ophthalmology has been recognized as a surgical specialty since 2000 BC. There are little bit discrepancies are there, but the first description of cataract couching, what the picture shows, was done, and they have a very clear-cut guidelines, indications of surgery, and contraindications for cataract surgery when they are doing couching. So I think they are far advanced, considering what we really do not know that era yet, and probably documentation was not proper. So coming to a little bit, I'll mix history and basically innovations that change the retina practice over years now. So few important aspect what I'll talking about: fundus visualization, photography and angiography, OCT, anti-VEGF drugs, evolution of VR surgery, and what future we have ahead with us. So fundus visualization again is a very interesting history. Jane Mary was the first person who observed fundus details in living objects. Basically, accidentally, we realize he immersed the cat's head under the water, which neutralizes the effect of cornea, and that way he could visualize the fundus. 1884, Adolf Kushman, he made an attempt, but he did not know how to visualize, how to illuminate the fundus to see the retina. But he had tried vertically, but he is known as his work in respiratory disorders. See, all these diverse interesting issues, interests they have. Now, probably Helmholtz was the first person who invented the ophthalmoscope. 1885, and last year, 170th anniversary of invention was celebrated. And this was actually allowing vitreous retina and optic nerve examination, and that created a change entire practice of ophthalmology, the way it is practiced, and it is at that time even comparable like a telescope, which is invented in 17th century, and stethoscope in 19th century. Basically, one of the most important invention it was considered at that time. And not only that, subsequently I'll get few slides that the principle of this ophthalmoscopy, particularly monoocular ophthalmoscopy, indirect ophthalmoscopy, that helps to evolution of endoscopy, which is every field of surgery now we are using, and even examination as well. And that basic principles. And also Oliver Gulstrand, he brought up what we called as a reflex-free binocular handheld ophthalmoscope. And what principle was basically, when you see what we all learn, when you have these three images, basically when a light which is going inside the eye and which is other light reflecting from the retina. So reflecting light and how like a ingoing light should not crisscross each other. They should be, those reflexes should not mix up, and that if you can maintain and manage, then you get what we call as reflex-free ophthalmoscopy or excellent fundus visualization. Quality of image will be good. And that's what basically why we insist on having pupil should be reasonably well dilated. So like a rays which is entering the eye through the pupil and was coming out will just at a different level they are. And that again principle being used for endoscopy. And then subsequent evolution, you have a first indirect ophthalmoscope designed by Theodore Root. Charles Kippen, basically, he came out, added second lens, was what we call as a binocular self-illuminating indirect ophthalmoscope. Again, that revolutionized the practice of retina surgery. And now we have modern things like a video indirect ophthalmoscope and smartphone related activities. And because obviously things are moving very rapidly, but basic principle indirect ophthalmoscopes, what we are using is now binocular indirect ophthalmoscope. Most of them are based on a principle of Charles Kippen, which is like a binocular self-illuminating indirect ophthalmoscope. Coming to what it leads to, once you start seeing, you want to document. And then comes imaging. And this again on a principle of monofocal indirect ophthalmoscope. All fundus cameras, what we have, different gauges. Again, long history. Things started evolving. First photograph in human fundus is in 1886. Confocal microscope was coming in 1957. Initially, something was 20-degree view was there, and then we moved to 30-degree view cameras, which was standard for last almost 20-30 years. We were all our fundus photography, indirect ophthalmoscopy, of FFA, so not indirect ophthalmoscopy, fundus fluorescence angiography, everything used to be 30 gauge. Till subsequently, we have a first digital camera brought by Kodak in 75. Scanning laser helped us to take imaging through smaller pupil, and that was in 79. and then have integration between digital photography and fundus camera. And recently, what last 10, 20 years, what we are having wide angle cameras and what we call as ultra wide field imaging, where almost 200 degrees view we can get with color or rate free or autofluorescence, various different things. So again, as I said, principles of monoocular indirect ophthalmoscopy. We can have various color photograph where you have a white flash, and then you can have a red free or green, or you can have a along with white field angiography and ICG angiography as well. So typically this just to show you, this is a 30 degree what we used to work for last 20, 30 years. And then somehow we used to manipulate it to get what we all know as a montage. Used to go beyond somewhere around 100, 130 degrees, 140 degrees, taking multiple picture, and it's really used to be arduous task. What it lead to subsequently wide and ultra wide field visualization, where 200 degrees we can get the picture. So advantages where you have obviously enhanced resolution, short image processing time, so faster acquisition, better, basically when you have a media haze, you still get a better picture. And what actually practice changed for us for last few years is non-compliant patient, eyes with very small pupil, where we could see fundus, and quite sometime I still remember last few years till we got optos. There are a couple of my patient pupil was so small, I used to do, patient did not have complaint, come for 6 months checkup, I would say get ultrasound done, ultrasound says attached retina, and we would tell them leave it alone, just manage with that. That was only. And then 3 years back, first time, I am following that patient last 20 years, 3 years back when we had optos, first time I could get a photograph, I could see fundus of that patient on optos. And then obviously all our babies, pediatric ophthalmology, I am sure Sumita will know, and like all of our ROP babies, very difficult to visualize their fundus. And all these babies used to undergo general exam under anesthesia to visualize, have a detailed fundus evaluation. And almost 80-90% of these babies, we are able to get fundus photograph using optos now. And all the G examinations have stopped almost now. So this is what it goes, not going to this one. And what you see is a typical camera, 90 degree. This is a Claris, also can add on montage, that goes almost around like a 180 to, and then this is what you're having optos, almost 200 degree view in a just almost 2-3 millimeter pupil. And then you have Miran 10, other companies are coming up, there are a lot of things, like brands are there in a market, but basically that adds on what is our principle, giving that an optos is probably more commonly used. Now, when you look at it, this is like a 7 field area, typically ATDRS studies, we also talk and used to take a 7 funder, and that is what all studies were defined on, like a management plan and everything. And when optos came, we realized the 7 field used to be large one, and what is 7 field, what you realize now this much, and you are still this remain unexamined. And almost quite a few patients, when you see like majority of this, 60% of this lesion, actually diabetic lesions, they are outside the 7 fields. So all we used to miss once upon a time, we are able to catch up those now. You look at this again, like a capillary dropout areas, these neo vessels, everything would have been just totally missed what previous image system what we had, and optos enables us, allows us to do that. This is assessing adequacy of pan-retinal photocoagulation. If necessary, we can treat them again. And this is what I was talking about, ROP, which never used to get this picture, never could see. And for this, we needed only examination under anesthesia. With optos, we able to catch all these things, was everything in a single frame. Coming to the another major invention, what we have, we really change our practices, optical coherence tomography. This is just a timeline. I am not going to go in detail, but basically what it gives, basically principle works on a principle of low coherence interferometry, and what it gives us probably so almost a histological section of the retina, all 10 layers, which we study with histology. Optos is now with the resolution so good, we can identify each one of them. It can be 2-dimensional, it can be 3-dimensional, and is useful for diagnosis, planning treatment, and follow for retinal choroidal disorders. It's gone through again evolution. This is a time domain, and then slowly subsequent evolution was spectral domain. So we have a depth that increase, resolution has increased. Then we have so-called enhanced depth, which we could now choroid also can be imaged with this choroidal pathologies also can be, we can get it. And then what we have is routinely what we are using is so-called swift source. So you get an image of vitreous, retina, choroid, and even deep choroid going towards sclera as well. So giving like a living tissue histological section, which change our management totally. Lot of so so and this is beyond that now. This is a Canon. Just recently I was looking into it. Almost 23 millimeter of section, depth of 5.3 millimeter. So look at it, how the things are evolving, and then you have montage of that. It is goes beyond that. So almost entire fundus you are going to get with this. So and then obviously documentation, research activities, and obviously treatment plan and follow-up. Definitely things evolve over a period of time. And what we are combining now, wild field imaging with swept source OCT, this peripheral region, even with indirect ophthalmoscopy, we had difficulty visualizing. We can now have a documentation with this one and have a say, cross section. Your OCT help you to image this thing. So basically, good documentation, again treatment plan, everything will be easier that way. So life has becoming a little bit much easier. And then now added to that, you have a ability to image the flow in a retinal choroidal vasculature. What we have is OCT becoming now OCT angiography or OCTA, routinely we call it. So the biggest advantage is because when a dye-based angiography we do, the dye leaks, and that's the way it is a dynamic phenomenon. Dye leaks, and sometimes it obscures the blood vessel as against what we have here, because there's no dye here. So this blood, all these entire fundus blood vessels, including now choroidal circulation, there's no obstruction, so that you get an excellent view. And for study purpose, and again when planning treatment is helpful. Now this is a typical case. You have a top image, SDOT showing a PED, and have a subretinal like a fluid adjacent to it. Initial propofol, 3 weeks later, patient come with a hemorrhage here, and what you saw there is now seeing a nice network here, which we pick up on OCT, not fluorescent angiography, and then it was treated 3 injections, and you see the comparison that helps you to assess the like a treatment response, and obviously continue subsequent follow-up. This is again typically what you see is a CFAN, excellent view, and not on a FFA and ICG, it is on SSOCTA. So really it's almost as good as FFA ICG, and probably because now help us to dye-based angiography or invasive techniques, we really minimizing a select group of cases only we do ICG and FFAs nowadays, and this is now going to, this is a diabetic eye, in fast view, wide angle. What you see is these new vessels, you have capillary dropout area. Otherwise, what we used to see, all these things, FFA we needed to do, and has its own disadvantages, of course, being invasive, having allergic response, and other side effects. All these things is eliminated, and you have a combined OCT along with ICJ, OCTA, and this helps you managing these eyes comfortably well now. And additional, when you things are slowly start miniaturizing, we have now microscope mounted intraoperative OCT. So during surgery, it helps to study vitreoretinal interface disorder, basically relation retina and vitreous epiretinal membrane, left or posterior hyaloid. So so your surgery now become much more refined, and any residual tissue left over, that helps you to take care of that. And what we are leading here is now with a newer technology, and we are heading a future with a gene therapy, when you have subretinal injections, basically for a gene therapy, subretinal drug delivery system, lot of things going on. So intra-op OCT would help us to precise location at what level really, at what layer you are going to inject. That's becoming much more precise with these OCTs. And we have, of course, pipeline is always there, so-called Hydra OCT, have a dual length being used. Sparse OCT have a portable self measuring, and there is already, these are things are already in the market. I won't say is really future, because like a portable handheld OCTs are there, and even few companies like Novartis, their representative go with that OCT machine to patient's house rather than patient coming here, particularly monthly injections when you are giving. So a patient should come back or not, they go to get the OCT done and send it. And if there's no leakage, you say no need to come back, come next month, and all those going happening. Patient, they have saved the visits. and they have something 3D speckle denoiser basically help in this one to clear the noise and so get a much clearer picture, so minimize the noise. And obviously we are combining, integrating different now so-called multimodal imaging, combination of whatever this imaging modalities we have here, and miniature handheld wild field cameras, smartphone cameras, that also adding on this technology with a excellent resolution, that leads to now what we have telemedicine or telescreening. And obviously it is, I won't say future, is already diabetic retinopathy and ROP is very much in practice for and very huge success what we could achieve in telescreening. Coming to another, what having really changed our practice is anti-VEGFs. Now, this was 60-year-old diabetic, but this didn't have diabetic retinopathy, I would say. He had a juxtafoveal CNVM. Long back, I'm talking about. This is fundus fluorescent angiography. This was, and subsequently, what we did is, typically that time, we have a laser photocoagulation directly. Extrafoveal is fine, but juxtafoveal or subfoveal neovascularization, only way we used to do is laser here, an immediate laser picture. Then 2.5 months and 9 months, whole thing basically you burn it off, you create a scar. So you have a more, while looking at a controlled scar rather than having a large irregular one. So you get some vision is lost at immediately, but probably long term when you look at it, some you have reasonably good vision. This was another patient, just happened incidentally, came into OPD. So vision that time was 636. Direct laser was done to CNVM. You can see the scar, and this is 22 years later. Vision, he is still maintaining 660 and 36. And last checkup was like June 25. Though the scar is further thinned out, vision has dropped 360, but he still has some vision. But that was the way we used to deal once upon time when you have the subfoveal CNVM. And this, one of the lucky patient, just off the fovea. Again, laser was done. So now post laser, okay, after 25 years, he is maintaining 675 vision in that. And other eye developed geographic atrophy, what we are having a 160 vision. This was his OCT and picture. Lucky fellow, just off the thing, so having 6-7 point. But what I wanted to tell you, what we used to do once upon a time, just scar this out, burnt it out. So there's no neovascularization, but there's no retina as well, and there is a significant immediate drop in a vision. What it leads subsequently, but that scenario will change when anti-VEGFs came into play. So gone through initially identified in 1948 something like a factor X that was described by Michelson. And then 1997 then started treatment for basically they realized it helps to basically active neovascularization can be controlled using this so-called X factor, and then called as anti-VEGF. And then that's why they started using initially in colorectal carcinoma. The trial started in 97, but ophthalmology first use was approved for Macugen, what we call as 2004. And then we have quick 2006 ranibizumab came, aflibercept came in 2011. Then 2015 we have Intas came with their biosimilar razumab, and then brolucizumab, and 2022 what you have is now faricimab, which is like a combination of two, it works on two actors. So this is now what it leads to. This otherwise would have done laser. Vision is 6.9. We have burned it out. On anti-VEGF, what we are helping us now is to just try it out, try to maintain more or less same 6.6 vision. Other eye also, it did help, but because scar, things were, it's a large lesion, so yes, there is some compromised vision, but it's not like that we are burning out. So basically, anti-VEGF are helping us to, first time we are looking at it, either maintaining or some, there is some scope of further improvement in vision. The same thing with diabetic macular edema, grid laser or focal laser still we use now for extrafoveal leakage, but grid laser almost very selected cases we are going, and this is a typical example fovea in oval cyst and or multiple injections down, vision is maintained 6.6 in this patient. This is my ROP again, fluorid neovascularization here over the distant posterior pole, anti-VEGF, and then added laser help us even this baby manage, even there's no need of surgery as well, and having almost 3 years I am following. So Current use basically role in anti-VEGF and retinal disorders. What you look at it, basically look at it helps to reduce the edema and regress the neovascularization. And I use the word temporarily here because unfortunately the major drawback with anti-VEGF is have a limited duration of action. And what we need is repeated injection. And none of us still have any answer now, except probably I would say ROP. Other disorders where we can diabetic macro edema secondary to diabetic retinopathy or vascular occlusion or other uveitis entity. So how many injection in that case we need? We need to keep on injecting, and just generally somebody say 3, 4, 10, but basically the problem only is nobody really has answer, and we need to continue injecting till patient disease is active. And that's why future leads for anti-VEGF. We are looking at it, looking for research going on to increase basically longer durability where you can minimize the number of injections. There are few trials, reasonably good results. We have something like, again, you are using this pulsar and photon trial where increased dose, probably if you have a higher dose, trials are already over for aflibercept, and is equally comparable safety they have shown, and probably they think that with 8 milligrams if you use, you may have the effect may last maybe up to 12 weeks, maybe more than that, instead of having around 2 months. Newer drug delivery system or something, what we call as like a sustained release system, probably you feel the thing and sustained release keeps on going, and maybe it work for a year or two or something like that. That's what we are looking at it. And then we have biosimilars. They are equally effective, but definitely help to reduce the cost, and what is called as biobetters, which are biological that are considered better than original molecules in one or more aspect. Basically, they are modified chemicals and having a much better or prolonged action and minimizes the side effects what we otherwise these drugs have. Coming to another big change is so-called MIVS or small gauge surgery. So just a short history about, as I said, like Charles Kippen has established retina surgery as a subspecialty, basically more buckles and everything, and what you call as is the father of modern retina surgery. But what Robert McKemer came with, first vitrectomy he did in 1917, what he came out with a so-called whisk, where one single instrument used to have everything. It's a 16 gauge instrument, and one single port, you see the big hole. This is a crude way, difficult to get those old videos, but used to do everything through one port. It has its own limitation, but he showed that yes, vitrectomy can be done and eye can survive without vitreous, and that's why he's called as a father of modern vitrectomy surgery. Now, then certain modifications happen, added on like a rotating cutter, it become like a oscillating cutter, and then vitreopatch payment came with that, but they all were full function probes. Basically, all the functions were in one port. But then what came with O'Malley and Haynes, they came with a split function probe, and that really changed the vitrectomy, vitreoretinal practice using a biomanual technique where like instruments become lightweight, become more precision, small size sclerotomy, so they heal early, better illumination, and because you use multiple interface, so maneuverability has increased. Coming to Indian scenario, prior 1980, there was no vitreoretinal surgery in India. Dr. Badrinath Chief, we know, and we were fortunate enough taught by him, and Dr. Nam Perumal Sabi brought this concept of Charles Kippen to India, and Dr. Nagpal brought the European concept of vitreoretinal surgery to the Indian scenario. These are three what we call as trinity of vitreoretinal surgery as far as India is concerned. The first vitrectomy machine was brought by Payman, and Dr. Nam brought that machine to India, and first vitrectomy in India is done by him in Madurai Government Hospital. This was the machine, and first vitrectomy done in, as far as I know, in Chennai, if I remember well. Dr. Nam came with me, he used to travel, he brought that machine to India, Chennai, and here it was done in, I think, Government Hospital, then in Shankar Nethalaya. Dr. Badrinath then worked with Mr. Wilson, the mechanical engineer, and we have our own prototype vitrectomy machine, used to work somewhere 400 cut, but used to get the job done. So conventional 20 gauge technique where all these instruments, when split function instrument came and lasted almost 30-40 years, very well refined. That was become standard of care as far as vitreoretinal surgery is concerned. We had a long experience. most important, we have wide range of instruments with him, and sturdy instruments, and like this is like a 20 gauge curved scissor. You look quite big that way now when you look at current scissors, but yes, we all trained with this. We were very comfortable with this. And obviously, because over a period of time, cost has come down, so they were affordable to everybody. However, somewhere around 2000, things have changed again, evolving with metallurgy, miniaturization, and then we have small gauge systems. We have wall micro cannulas, and we have insertion trocar system. Basically, trocar cannula system was introduced now, and this is what 20 gauge we used to do. Fixing infusion cannula and then other sclerotomies. You have to open conjunctiva, big incision, bleeding, take the suture, replace suture before putting infusion, and this is the way current scenario where what we do is just straight entry through transconjunctival and you are done with. This is little bit, those we all used to do, but now look at this, sounds really crude. So, of course, some amount of bleeding will be there. And you have their own plugs, and these are also, they are having their own walls. And you know, there's hardly any bleeding there. And of course, when you make opening, large opening, suturing become also inherent part of it. So go back, suture all these things. So it used to take quite a long time. Opening and closing itself used to be a very, very long time. So again, suturing is something like that. Pre-place suture, you release this, and then suture whole thing back. And what we really works it now is, you just pull the thing out, hold your Q-tip for a while, and it's sealed. It's done with. And simpler than this is, generally I prefer this ROP where we pull over it, and just because they are 27 gauge instrument, 25 gauge instrument, there's hardly any necessary to suturing nowadays. And that's why. So what actually it leads to, this is 1 week photograph. We have a difficulty sometimes make out which are we operated. That's the way we see now what is a 20 small gauge surgeries. So obviously advantages are transconjunctival, no significant change in surgical technique. Basically instruments are more or less same, except they are smaller gauge. Now, because you use a trocar cannula system, interchangeability of instrument between entry sites, you can use any sclerotomy for any instrument. And obviously, being a sutureless, your total surgery time has significantly cut down. Patient, post-surgery, patients are much more comfortable. And obviously, you need to do additional surgeries like glaucoma. Usually, we prefer to write careful conjunctival opening. We don't open conjunctiva now. Okay, so with the subsequent innovation, something called as port optimization. Now, what you do is, this is a scissor and this is a cutter I am using. Cutter itself, because port is very close to the tip, the scissor with a low cut rate now can be used as a, like a cutter can be used as a kit. So you minimize the use of exchanges. So no need of multiple instrument, and most of the thing can be done by exactly precise each nail, each attachment, the way you cut with a scissor, you use a cutter here. Okay. So I don't have to go back and forth with scissors, forceps, and then again going with a cutter, clear it up. Yes, cutting rate also, there is evolution. We, as I said, started with somewhere 300, 400. Alcon came with their series 10,000, 20,000 with a 600, went to 7,000, and then we have something called as 1,500 cut rate. Bosch and Lomb comes with a gold color probe, vibrating nicely in your hand, but that used to call as lightning high-speed cutter. The big name was given lightning high-speed cutter because that was the thing. And what it leads to eventually, with subsequent evolution, we have almost now reached 20,000 cut rate. We are routinely ways, and Alcon is just, I think in few couple of months, they are coming with 30,000 cut rates. Do you really need this high cut rate? So what happens with a higher cut rate, which allows vitreous saving without having much turbulence? And so when you compare these two pictures, the turbulence, fluttering what you have compared to here, as you see, so higher the cut rate, lesser the tug, and so obviously safety margin has reduced, your tug on the retina is reduced, And what is typically, even if you have detached retina here, you see when you're cutting this thick vitreous band, there's hardly any movement of the retina. What it leads to, exceptionally good safety margin, minimize the risk of intraoperative complication when you deal with this instrument. And then little bit subtle modification, this cutter become bevel tip. The moment this angle, this is again away from the port retina, this become reduce the distance between port and the retina. And what we can do is literally now shave the retina, vitreous over the retina, not retina I mean. So typically this is animation, and what it shows is exactly same way going between the retina and membrane, and you keep on like a lawnmower, you keep on shaving the retina. You don't again need scissor. Minimize even bimanual surgery as well, and that helping us to cut this out. And obviously with a wide angle thing, what we need is illumination is more. Obviously we need more illumination, and for good visualization of vitrectomy system, there is a little bit changes in visualization as well. So this is what we used to do, older contact lens system. We used to get 30-degree view, nice view here, and you want to go a little bit periphery, you use a prism. That will take you around 50 to 60 degrees. But the biggest advantage was exceptionally good resolution it will have. So, I mean, those videos and you look at quality, there's unmatched. The problem was treating the periphery. With a depression and with external Q-tip you use, with a prism you go to some extent, but the disadvantage was when you have a prismatic edge and that effect, you lose the depth perception. And particularly when you want to do fluid direction in these eyes, huge amount of reflexes. You used to use a 90 diopter lens, biconvex, visibility significantly get compromised, your field of surgery is significantly reduced. And these are the main problems, as I say, small pupil. And then you have corneal edema, corneal media haze, some blood or something, sometimes extremely difficult to visualize these eyes. So we have now wide angle viewing system, biome, and iBus. Basically they revolutionize the system. Initially they have their prototype, they have difficulty, but with biome and particularly recite what were more common is being used everywhere, they give almost around 128 to almost 130-degree view of the fundus without moving your eye sideways. And of course, you have contact lens system. AVI is still there. We have one set with us. We are not using anymore because the sterilization, other issues are there. But like a workhorse is now is Recite and Biome. And what you see there basically, this is a picture, Lander system, contact system we used to see, the same eye. This is much what you are seeing here with the Landers, and the same eye, when you put a biome, look at right up to the periphery, you go laser mark everything. So you have a large field, so your orientation is far better when you are working in these eyes. And see this picture again. Previously you have difficulty posterior pole. We never used to see peripheral area, and you used to struggle. And what you see the view now, what you're seeing with a Recite view, seeing this patient had a giant tear here, allowing easy manual and excellent visual, like a resolution as well. So even we have a small pupil. Okay. So with that pupil also you get an exceptionally good view, as you see the still is having enough wide view here, and also advantage even if you do fluid direction, quality of view will be exactly same with a great depth of field, and obviously it makes our job relatively easier. And what we are now having is a so-called 3D head-up display. Cost goes on huge now, but basically this is Alcon system 1 and Zeiss. They are the two main systems available in the market. So basically what you do is term called as head-up display. Basically a lot of people are talking about, all VR surgeon, occupational hazard, all of us are having back problem, neck problem, and almost everybody has gone through some time of that. So with a heads-up system, where typically concept with a aircraft pilot, fighter pilots, and they used to have a visor, helmet, what they use, and all display, all they get on the visor. So they really do not have to look at the panel because that much of time they don't have the speed they move. So that concept brought in, and what you have is you look straight. And when you look straight, everything is, you're really not looking at through the microscope to the patient, but directly looking ahead. So this is the way. So you look at this screen, It is 4K and now it's 8K is coming up. So so not looking through, patient is down here, but you are directly looking at here and your hands are working down. Of course, you need a now 3D glasses for that. The biggest advantage here is probably observers, if you are arriving, basically surgeon and his assistant used to see through microscope. But here, obviously, everybody in the room can see, so it's exceptionally good teaching instrument. Display is good and also exceptionally good depth perception. But we have, again, it's little bit limitations because you have to tilt yourself one side. Distance of the screen has to be very precise, 1.2 to 1.5 meter from the surgeon, otherwise depth perception distortion will be much higher. And ultimately, you are looking at a digital image and not right directly tissue. So certain steps of surgery would have been difficulty. So you can integrate now OCT over it. So previously, this is intraoperative OCT I was talking about. So this also comes on display. So you give simultaneously operating, you can see this. So at what depth you are working, it helps you out. And this is coming with a Bionics Vision and then another Israeli group coming up. This is actually, in a true sense, head mount display. So the disadvantage what you have with a 3D, what you having a ingenuity, like you look little bit one side because patient is in front of you, and that in fact sometimes cause problem with neck. Here, right in front of you, everything you really do not have to do, your neck, back, everything remains straight. So still they are prototype coming up. So also what it leading to now giving you immersive visual field, adding AI, close-ups, and you can add on other imaging modalities, integrate it with during surgery. So you have everything, all your information available on display, what you are going to get it here alone. So this is just heading up. So just to a word about future, I'm not going to go robotic surgery. We are still, will take some time to have a robotics part of it, going to that. So gene therapy, basically what you look at a genetic modification of DNA where either you replace the mutated gene or add a missing gene or modify the existing one. First human genome project was almost 25 years back now, and there's increased interest in ophthalmology gene therapy mainly because we have easily accessible for treatment because we just have to inject in the eye. Has immune privilege status. Basically, I can accommodate the antigenicity of viral vectors, and it's a tight blood ocular barrier. So chances of having other systemic side effects relatively are less. And basically what you called as they use adeno-associated viruses as a vector. So these are 4 ocular conditions as of now being targeted. I'm not going to go just very, very much in detail. Luxturna was the first drug approved, and it was targeted RP65 specific gene, and they have trial 93% success rate in phase 3, but it comes at a huge cost. And basically, most important aspect here is treatment does not restore the normal vision. So whatever you have a small window in which we can use this medication drug. Stargardt disease having a multiple trials going on, some phase 2 trial in Starlight trial, where significant improvement in vision has been shown. Basically, it is targeting ABCA4 and ELOVL4 genes. Dragon trial has already completed phase 3, and they have shown almost 36% of patients have reduced the atrophic lesion. But vision is more or less maintained. So where they are looking here as a vision to maintain, not further reduction. And this Belite Bio, that is a company, they have now already submitted for FDA regulatory approval. It's coming something in January, February, and they are having, I think recently, probably I'll be attending next week, like a Tinlarebant, that is what is drug being used. I don't know, we'll get to know when they want to start the trials here. There are another trial for retinitis pigmentosa, just going to, not going to go in detail as of now. But challenges what you have is, these all gene therapies are very, very specific to the genes. That is, one must identify the specific genetic defect and then you can use it. So it's a limitation which comes with a very, very high cost, and we still have a lot of way to go to. We need to devise scalable manufacturing solution, delivery methods of gene therapy, and a lot other practical teething problems we will have. geographic atrophy. There are, as of now, two drugs are approved, but still lot of work has to be done. Artificial intelligence is a buzzword nowadays everywhere. First AI-related publication was on diabetic retinopathy, and ophthalmology is very much in, apart from other medical subspecialties. And Shankar Netra particularly are very much involved in diabetic retinopathy when Rajiv Raman was here, and obviously Arvind group of hospitals. So basically, that also helping you screening, coverage, resource management, and automation of the treatment as well. So a lot of AI algorithms are being practiced now for both diabetic retinopathy and mainly ROP as well. So that way is helping us improve efficiency of healthcare system, and it's supposed to assist clinicians in processing ever increasing volume of multimodal data, and hope that it gives some extra time for doctors so that they can have better interaction with patients, and of course so-called personal management plan.
Last year at Google
This is
I/O,
what just
we announced
Raju's
Google
video.
AI. It's a collection of our teams and efforts to bring the benefits of AI to everyone. And we want this to work globally, so we are opening AI centers around the world. AI is going to impact many, many fields. And I want to give you a couple of examples today. Healthcare is one of the most important fields AI is going to transform. Last year, we announced our work on diabetic retinopathy. It's a leading cause of blindness, and we use deep learning to help doctors diagnose it earlier. And we've been running field trials since then at Aravind and Sankara hospitals in India, and the field trials are going really well. We are bringing expert diagnosis to places where trained doctors are scarce. It turned out, using the same retinal scans, there were things which humans quite didn't know to look for, but our AI systems offered more insights. Your same eye scan turns out holds information with which we can predict the 5-year risk of you having an adverse cardiovascular event, heart attack or strokes. So to me, the interesting thing is that more than what doctors could find in these eye scans, the machine learning systems offered newer insights. This could be the basis for a new non-invasive way to detect cardiovascular risk. And we just published the research, and we are going to be working to bring this to field trials with our partners.
Of course, we have challenges. We need large, more diverse and representative database that fully represents the real life. Need to develop disease-specific consciousness and provide a comprehensive large volume of image gradings. And if the quality of image is not good, obviously outcome is not going to be what you put in going to get out. We have greater synergy between healthcare professional, patients, and data scientists to improve the software infrastructure. So these are practical efficient difficulties going to go ahead. So the recent pharmaceutical technical innovations have revolutionized management of retinal diseases. It will help to achieve proper diagnosis and plan appropriate management, and thereby helping to improve the efficiency, efficacy, and reduce the side effect. But obviously, high cost limits the accessibility and widespread adoption. Thank you very much. Thank you very much for patience. Most welcome.
When you were talking about the innovations, the transfer from 20 gauge to 23 gauge was a big boon for the glaucoma surgeons, because we looked at our trabeculectomy after combined with vitreoretinal surgery or after vitreoretinal surgery about 20 years back, and the success rate was about 40 to 50% for IOP control. And last year we repeated it with the recent data, and we found at the end of 2 years it was 8% success rates.
Oh.
That's a remarkable improvement, and thanks to the innovations in vitreoretinal surgery.
Pramod, can I just a quick comment? Right. Can you hear me?
Yes, madam.
No, very well covered wide spectrum of VR, how it is evolved over a period of time. So, fortunately, VR, the technology kind of is implemented very well. In glaucoma, also we have a lot of technology that evolved, but it has led into some of the issues. especially the false positives in the diagnosis, etc. Do you consider any limitations of technology in VR management?
Limitations? No,
In
any
the
type.
sense that how the technology has a negative effect on the treating the VR disease?
Well, the base major issue is the two aspect I could see is obviously with the technology cost is going to go high. That's a major problem, major hurdle. And second, obviously apart from cost, also with a newer thing coming up may not be accessibility in is I mean easy accessibility rather I would say. So probably these are two major hurdles I can think of as of now, and that we are already facing a few things.
Yeah, no, my question is in terms of misdiagnosis and mismanagement because of the use of technology too much.
Well, I think yeah, what is happening is now EMR rather than your drawing, your copy paste we are doing. Okay, and I mean so joke apart, but yes, what is happening is basic clinical skills are slowly we are losing because things are becoming so easy now. Because instead of having a 90-day after examination, 78-day examination, and proper fundus evaluation, what we used to do, we used to make a big fundus drawing chart. Now it's easier way, just send for get optos done. What we am not realizing, yes, documentation is good, excellent way, less scope for mistakes, but we don't realize while making a fundus drawing, that was opportunity for us to thorough examination of the fundus. So, and that is what we are lacking, and that's definitely when you missed findings, obviously, then of course you have a repercussion on your subsequent diagnosis management when the findings are not right. So things have become, you are taking easy way out. Probably same thing, not only I'm talking about ophthalmology, with the echo coming up, stethoscope users are practically, they stop using nowadays. Okay, so like the old clinical skills used to have like a percussion and auscultations and all those things are we are definitely losing on this. That's and long term I really do not know, but yes, unless you have because see operation theater, if you take case for surgery, your OCT is not going to help you. Your clinical skill, your examination taking and how thorough your examination, that only is going to help you. I think that definitely going to have some impact on our practice.
Where does the scleral buckle stand today?
Yeah, that is again okay. That's exactly I think what I was going to mean it, because it's not like that scleral buckling outdated. People do not want to do because they lack indirect ophthalmoscopy skills. Okay. Because I cannot, but I don't want to accept that I can't do indirect ophthalmoscopy. Easy way may out to just, and because you need to bend your back. Yes, it takes time, and scleral buckle obviously need a lot of decision taken on table because you examine a lot of things, calculation, assessment you need to do on table. Vitrectomy that way is easier. So you go inside and you see there. You don't have to have those measurements, other thing, and you have so because I am not doing indirect ophthalmoscopy regularly in OPD because easier for me to get optos done, and optos give you much larger picture rather than I am going depressing all around. So time also is saved. I think that is what bringing out so-called easy way to say buckle is a outdated procedure. I don't think that way. I think fortunately we all here still specific cases we still insist on doing scleral buckle. Otherwise it's become other line. First you do vitrectomy, and if that day I had one of our senior colleague somewhere else, he says Pramod first surgery should be vitrectomy, अगर fail हो गया तो फिर buckle के साथ re-vitrectomy करने का. I mean, it's and this is one of the very experienced person. I think that's not a way. Fortunately, I think we still stick to buckle, and we have cases since still once you do buckle is done and it's done everything well, nothing happens next 30, 40, 50 years. We still following our patients.
Thanks, Pramod.
Good evening, sir.
Good evening.
Sir, what motivates you to take Sunday morning class 7 a.m. year after year, batch after batch?
You modified Pradeep's question why I am still in VR. Okay. Yeah, basically, and I would say because I want to learn. The simplest answer is that. Because, so if you want to teach somebody, you need to really go through, you study much harder, much more than your examination. Because you want to teach somebody and somebody asks question, you can't say, I do not know the answer. Okay. And I enjoy that is because I want to learn basically. And because probably I would say, again, motivation, I am still here, is you people. Because you people keep on asking. And because you ask, I forced to read. And because I am forced to read, I update my knowledge. And I am good probably, if I think I am good or everybody think I am good, is because of probably being a teaching institute. That's the biggest advantage being in a teaching institute, because you have student. And your students keep on asking, and they are actually really stimulus. And satisfaction is when they go out and when they do well, and then somebody asks, "Kisne sikhaya aapko?" I think that satisfaction unmatched, I would say. Yes.
This looks like a ragging session.
Yeah. Putting both of us in an awkward, difficult situation.
Well, I've seen him for maybe 35 years. Yeah, no, 34. I hope I continue to see him for another 34. That gives you your answer.
So VR comes with a lot of setbacks and cases that don't go well. Especially with ROP, I remember not all cases turn out to be well. But then I remember you telling me in my month posting where one retina had attached very well, and you said that one case was worth all the attempts that you did for all the 100 other babies. But even then, how do you cope up with that, and how do you move on to the next case without that doubt in your mind?
Probably what you see is everything, whatever, like any specialty or anything what we do is, there's a lot of background homework goes on it. All of us do. And that's what I keep on telling you people. When you see the patient pre-op, previous evening, he's just not seeing, you decide whether surgery is necessary or not. And certain basic steps. You go back home and then plan. It's not like I'm going to do 23 gauge vitrectomy. It doesn't work that. Where I'm going to sit, whether I'm going to open conjunctiva or not, where my sclerotomy is going to be there, sclerotomy, where I'm going to sacrifice lens or not, where I should start my vitrectomy, whether I'll be able to see incision canal or not. If I can't see, what I'm going to do. Initially I used to write 1, 2, 3, 4, 5. I used to make my own drawings, small sketches. So basically that great orientation. For example, you have a cornea, you want to put 4 iris hooks, you want to have 2 stab incision at either side because you want to release the synechia, then want to have phaco section to do phaco also, and then you have subsequent. So now where all those 7, 8 cuts are going to go? You cannot go haphazard. So make a small sketch, draw each one, which clock hour, where it's going to be, how far away they are, which gauge we are going to get. I used to make those sketches to start with. Of course, now most of the thing went on, you rehearse 1, 2, 3, 4, that it goes. But yes, coming to your, also when you operate, you anticipate some problems. Now, end of the surgery, things doesn't go well. You sit and re-look at it. Where things went wrong and what I could have done to avoid those. Or in future, what I'm going to do that I won't land up this type of problem. Now, even everything goes well, surgery went off well, probably sometime you struggle, but everything goes smoothly. Still, you sit back, end of the case, or sometime you are busy running theaters, end of the day. Recollect all the steps, first step to last step. And actually now it's easier because you have, if you uninterrupted, unedited video, if you have, easier to go through all your steps. Sometimes you really, things you miss and you go through, that's easier. So what we typically use the word, not exactly post-mortem what police do, but every operation, every skill, every activity done, what you call as post-mortem, basically relooking, revisiting all the steps, activate what you do. And even if everything goes well, then you think, is there a way I can simplify this? Is there a way I can make easier for me for my next case? Certain steps you feel difficulty. You manage, but you feel you are not comfortable. And then go stand with your colleague when he is operating. And then you focus specifically, look for specifically that case. Now I started doing cataract surgery. So Dr. Srinivas Rao was there. Fortunately, we have same theatre complex. Dr. Naveen Jaikumar was there. Dr. Prema used to be there, sharing the theatres. Then quietly used to go stand next to them, looking through. So then look at it. These are the step I am difficulty. Why my rexis is running out? Then I see specifically what Dr. Prema is doing, why her rexis doesn't go out. And then you go back and just practice and inculcate that. Certain thing, no, consciously, unless you do that, you will not. As far as ROP is concerned, that yes, you need a passion, but certain cases you know prognosis is bad. And you also know if you do not operate, that's chapter is closed, 100% baby is not going to get back vision. But if you take a chance, you operate, but out of those 100, 10 or 15 babies also get ambulatory vision. You feel that you at least help somebody, you have touched somebody that is helping them out. And that, yes, every time parents come, they sit with you, they realize did not work out. Emotional burst is always there before surgery, after surgery, and they sit, cry. You need to give them time, obviously. Can't send them out in 2 minutes because my other patient is waiting or big file is there. You go, you also be part of them. Feel frustrated, sometimes annoying, sometimes depression. But then you look back, yes, but anyway, otherwise baby would have lost. Only thing is probably parents may say you are responsible because you did surgery, did not work out. But you as a person, you know that it already would have lost if would not have done anything. But at least you know, at least of this few, you can make some change in their life. And when you see few, 1 or 2 of this, that is stimulus, go on next 10, 15 cases. So few 1 or 2 or 3 of this will come back with some vision, they are being moving around. That's what we have that boy having a ROP surgery, ROP conference we have for inauguration, 11-year-old boy. And next day, this year he came for a checkup, he brought me his own drawing he said, doctor, I drew like a jazz last time, but then I realized you have Honda City, so I have made a drawing for Honda City, and this is your Honda City. I mean, it's make you the way satisfaction you get out of this. The other boy, both eyes I operated, he is doing engineering now. Okay? So these are few cases you need to just going on. These are all your stimulus for you, inspiration for you.
You would like to speak something?
And most importantly, you know that it's not going to be everything going to be all right. So you are already mentally prepared for that. That's the most important thing.
So Girish here.
Yeah.
So you, Dr. LG, Dr. TS, Chief, I mean, many or more people have been the torchbearer of SNVR for the past 4.5 decades. What should the present batch and maybe the future batch of consultants do to continue that SN is at the forefront of VR?
No, they are
for
good.
decades to come?
Let me accept they are really good. They are really good. Yeah, but things are changing. Technology is evolving. Life is there. But yes, that and lot of distractions also are there. Okay. So what needs to them is really basically they need to decide their goal, what they really want in life. Money, obviously, financial stability is obviously necessary. But I think SN still pays enough, you can comfortably live now. Let me tell you that one. Okay. When I joined, Dr. LG spoke to me. First, the day he offered a job, he says, Pramod, I want to offer you a job in Shankar Netala. But one thing now I want to tell you, by end of second year, probably you may be able to buy a scooter. But your colleague who has finished and going out by 6 months, he may be having an air conditioning house and 4-wheeler. You need to take a call. So basically, what I would say is the same thing. Basically, you need to decide what you want. And they are, I'm sure they, I've seen everybody, and almost most of them are, I was mentoring them. They are really good. But I think ultimately, final thing is they need to take all what is their goal, what really they want to have in life. Uh, and as I said, academic institute is always better if you want to really pursue as a career, as a really that specific field specialty. Once you move private, because there are always a lot of other issues are there, because there's nothing wrong in that, but they have other areas, other interests, or other compulsing reasons we need to move away from certain things. That probably is not there, and I think SN has excellent culture, what I would say, working culture, family culture, I would say. We all are happy, as of how you are. And it's true, we all as a family. I was talking to Jay Prakash today. We realize when issues come, certain issues, SN is always there, help you out with your personal and every difficulties in life. When if they want to continue, yeah, exactly. They have to be focused. They have to be not get carried away with distraction and other things. I think probably, and also that's what my last slide is. Everybody is beginner, not as master. So everybody comes with time. Everything comes with time. So you need to have patience. Go on and on and on and on. And there is a time that you will be reached somewhere where Dr. LG is there, or Dr. Tarun Sharma is there, or Dr. Bajnan. They've gone through. Within 2 years, 3 years, you cannot say that I should get all laurels, I should get all so-called prizes and awards, and everybody should know me, and then I should be the thing. It doesn't come 2 years, 3 years, 4 years. It needs time, and you have to work for it.
So, but as a institution, as a management, what can we do to again ensure that Netralaya still is at the forefront of VR?
Yes, we have to keep updating, and technology-wise as well. The advantage what we still have, because again I would say academic, so we have we keep on learning, updating ourselves. Conferences obviously is important to attend, may not be every meeting or all the meetings in a year, but at least certain specific meetings, and that subspecialty I would say definitely people should go. So there are certain meetings where all new things are coming up. And also important thing is, yes, as a management side, cost of living is increasing. Again, I would say temptations are there. So it's become as a senior people, have our responsibility here to ensure that at least we match to some extent, that they won't have that temptation to step out. So because ultimately, end of the day, yes, because everybody has to live, survive in this world. Tomorrow somebody says, my son or daughter, I need admission in certain specific institute. Nobody is going to say, because you work in a Shankar Netra, a non-profitable organization, so no need to pay donation. That person has to create his own corpus. So probably we, from our side also, we need to ensure that they are comfortable financially. Work ethics, I think Shankar Netra, there is no doubt about it. We are very good at it compared to other institutes, and I think we should continue the same way. We really do not have to change. But only thing is, look at it that yes, match with more or less, ensuring they are comfortable and also financially as well as work-wise. And obviously, good family environment we are still maintaining. I think we should continue. That will continue. I think that should not be. Problem only with temptation if they leave out.
Thank you, sir.
Good evening, sir.
Good evening.
Sir, for the newly joined fellows, so how do we maximize our VR fellowship? So first is like, as you have replied to ma'am, first is introspection and journaling. So and so also thinking about the new AI, do you know any applications or artificial intelligence that we should be aware at a personal level and we should follow?
See, everything comes with time, as I said. And what you need is always, your foundation has to be strong. Unless you have a strong foundation, unless you know basics, and everything you build over it, over a period of time. Shaky foundation, everything comes down. Okay. So go step by step. master your basics, and let me tell you, basics are never outdated. Basics are always basics, and basics are important. And once as you grow, and then yes, then there is no limit what you want to. Yes, AI will come, this new technology will come. Now, technology also comes with, as I say, cost, price. Companies, they have to survive. They also have their own competition. And unless they come with something new, they won't be in market. Okay. So by the time you buy instrument, it is already outdated because company is working on something else. And every 6 months, 1 year, something new thing come. So there is no into it how much you should learn, how much you can have this. It's like ocean. And you take one glass after one glass, and they won't be enough for you. So, but basically ensure that you go step by step, have your basic, okay. And after, like all of us so-called we are surgeon, but still we have, each one of us some niche areas, you focus on one particular ideas. So as you grow, as you say, in your field, what you call as, you know more and more about less and less. Okay. So that's the way eventually, because you just, you have 24 hours in a day, and you can have, you need to limit yourself, and then you have your focus on one certain aspect. But for that, to know less, more and more for less and less, first you need to know what is that entire spectrum. And then you choose your field, then you move forward. Time to close.
Thank you. I thank each and every one of you consultants and all my dear students who have made it as part of this series, attending all my instructions that you please come on time. Please bear with me. And academic department welcomes any suggestion of such type of sessions which we can inspire all of us together and give a little boost to the education. Thank you.
Thank you very much. Thank you very much for patience hearing. Thank you.